Hello, I'm hoping everybody can hear me now. My name is Sarah Callaghan, and I'm Editor-in-Chief of Patterns, which is a journal of data science published by Cell Press. And I'd like to invite you all to, or thank you for coming along to this webinar on mathematical modelling of COVID-19. Co-moderating with me is Stephen Krantz, who's Professor of Mathematics at Washington University in St. Louis. And we've got two excellent talks for us over the next hour from Natasha Martin, who's Associate Professor of Medicine at the School of Health Sciences in UC San Diego, and Arnie Srinivasa Rao, who is Professor of Medical College of Georgia, Augusta University. And I will be monitoring the chat and questions as we go through. So if you have any questions, please do feel free to put them in the chat there, and we will deal with them towards the end of the session. So I'd like to thank you again for coming along, and invite Natasha to start off with our first presentation. Take it away, Natasha. Thank you.
Thanks so much, Sarah, and thank you everybody for joining today. So, as Sarah mentioned, today I will be talking about epidemic modeling of COVID-19 on university campuses. So, the nature of the problem is that by their very design, universities are purposely configured to foster interaction between students, faculty, and the staff that work there. And so the question is that we have an ongoing COVID pandemic, and yet there are places where the local situations may allow for a partial or full return to campus in the fall. And we want to know how we can best reduce SARS-CoV-2 transmission and facilitate a safer return, acknowledging that any amount of interaction provides some risk, but we want to reduce that risk as much as possible. So today I'll be talking about 3 studies which have looked specifically at how we might approach things in the fall in terms of reducing the risk on university campuses. The first will be work that we've done at UC San Diego, modeling various strategies, as well as our overarching COVID strategy that we've developed in the fall, and partially informed by that modeling. And also discuss 2 very important studies that were done at Emory and University of Penn in terms of their campus reopening strategies, and talk about the general findings across these 3 papers. So at UCSD, our return to learn approach is really centered on 3 foundational pillars. The first is risk mitigation, understanding that we want to reduce risk on campus through, for example, personal protection and masking, sanitation efforts, as well as structural configuration efforts in terms of, reducing the density of housing or minimizing the class sizes in order to reduce the risk of transmission. Additionally, we want to be able to detect outbreaks early. Through that, we'll be performing symptomatic and asymptomatic testing programs, as well as environmental monitoring, such as wastewater testing, to see if we can detect outbreaks at an earlier stage through those measures in order to best direct our more intensive testing measures to detect outbreaks. Of course, these need to go hand in hand with traditional public health interventions such as case isolation, contact tracing, and exposure notification. And we're very interested, as well as molecular sequencing, to help us understand growing transmission clusters and how to best intervene. And our entire approach will be adaptable, understanding that we want to take the information that we learn in real time and kind of adapt as we go, so we are always using the kind of best approach tailored to the setting that we're in. And the aim is to integrate all of these different pieces of data and different data types into a singular framework, which we've called SMART, the Multidisciplinary Integrated Real-Time Intelligence System, which, as I mentioned, can kind of take in the information that I described on the previous slide and use it to adjust our approach as we go, instead of kind of the traditional public health approach, which is to use 1 or 2 fairly crude metrics to decide whether to make kind of binary decisions about whether something is open or closed, and instead kind of take the information as we have it in real time and make more incremental adjustments to our approach, so in a data-driven, evidence-based way. And so we've done various modeling pieces to try to understand the impact of different approaches. The first shown here on the slide in terms of thinking about the structural configuration on campus. So our starting question was, what was the impact of various housing configurations and classroom sizes on the risk of transmission? To do that, we developed an agent-based, network-based model. It captured the complexities in terms of the population types on campus, so graduates, undergraduates, et cetera, as well as their location and class registration data that we obtained from UCSD. And the basic structure of the model is shown here on the slide, where individuals are represented by circles, the red being a student that lives on campus, and they may be situated within a dorm. The dorms may share bathrooms with other rooms on their suites and situated within a dorm. The students are also located in classes of different classroom sizes, and that again those networks are based on actual classroom size data. As well as those fixed networks, there is also a sort of network that changes over time, which is a random interaction on campus for everyone that is kind of on campus. And there are also off-campus students who have a background rate of infection because they live in the community and also are allocated into classes and have classroom connections. And so we use this model to look at things like the impact of maximum classroom sizes. So here I wouldn't focus too much on the numbers on the left, or really the actual transmission rate if an outbreak were to occur is uncertain in the fall, but we're really trying to look at the relative reduction in transmission with the limiting classroom size. And so you can see here that we get quite a high amount of transmission if there's no classroom size limit, but quite a substantial reduction in the cumulative number of infections if we limit the classroom size to 50. Again, a quite kind of important reduction with further limiting it to 24, but kind of marginal impact by reducing the classroom sizes further. And if we look at actually how those classroom caps actually reduce the contribution of each component to infections, here we show the contribution of each component, community, classroom, and residence, at the date that we achieved 20 infections. And with no cap, which is shown on the left, we can see that roughly a third of the infections would be occurring within that classroom setting. But if we maximize the classroom cap to 50 on the right-hand side, then we can see we reduce that contribution to 19%. So really kind of reducing the risk of transmission on campus, and the majority of our infections are seeding off campus. When we look at the impact of both reducing classroom sizes as well as shifting classes online in a sort of hybrid approach, we've looked at three different scenarios. So one where students, there's no maximum classroom size and students take their full in-person classroom load. A cap in-person scenario shown here in the yellow, where classes are capped at 50, but students still take their full in-person load of classes. And a cap and hybrid teaching approach here on the right-hand side, where not only are the classes capped at 50, but we also limit the number of classes that people can take in person. So having the number of classes that they take in person, with the remainder of classes being online. And with that cap and hybrid scenario, we can see that we further reduce transmission over here on the left, with the lowest line showing the impact of the cap and hybrid, as well as also increasing the time to 20 infections. So if we look at the horizontal line, which is the time where each curve would approach 20 infections, we can see that we increase the time to reaching that point by 30% with our cap and hybrid approach. Now, the impact with varying housing situations is not as straightforward. So we looked at what would happen if we had full density of students on campus, that's singles, doubles, and triples, or singles and doubles only, or just singles. And what we see is that we actually see increased transmission going from full density to doubles and singles because of displacing students off campus, and the assumption that students that live off campus have an additional risk due to their just living in the background community. Many situations here in San Diego which have higher incidence than in the university area. There's a reduction in transmission from doubles to singles only due to the benefit of individuals not having no roommates, even though we are still displacing some students in the community. So there's really interesting dynamics, and I think it comes all down to our assumption about what background risk people have in the community and thinking about how our housing situations might displace students into possibly higher risk environments in the community. But we really need to understand these trade-offs better to model these complexities. We also wanted to look at what testing frequency we need to detect outbreaks early. And so that's our middle pillar of viral detection. To do that, we put together a kind of basic compartmental model incorporating the natural history of the disease and really wondering about how asymptomatic testing can help identify individuals in these green stages, either if they're totally asymptomatic or in the pre-symptomatic period previous to symptomatic disease where they could still be transmissible. We seed an infection in this model, and we calculate the probability of detecting at least one case on each succeeding day, assuming a Poisson distribution from the number who test positive and the number symptomatic who would arrive for services for testing through health services naturally. We assume an 85% test sensitivity, and what we do is we calculate on the day that we exceed a 90% probability the number of cases that would be present in the community. That we exceed a 90% probability of detecting at least one case, how many cases there would be. So here this slide shows you the number of cases that would be in the community the day that we were fairly confident that we would have detected an outbreak with various asymptomatic testing scenarios, ranging from 0% on the top row to 100% per month on the bottom row. And you can see kind of reading downwards in the graph that the more testing we do, the fewer cases there are present when we detect an outbreak because we're testing, so we're detecting the outbreak earlier. And that if we want to detect an outbreak when there are less than 10 detectable infections on campus, we probably need to be testing greater than 75% per month. Now, one critical and certain parameter is the proportion of individuals who would naturally present to health services for testing. I think this is particularly relevant for campus-aged and student-age populations who are younger and may have more asymptomatic disease. In fact, a recent modeling analysis by London School of Hygiene and Tropical Medicine indicated that an estimated 20% of individuals between 10 and 19 had symptomatic disease, meaning that only 20% of them at maximum would be likely to present to health services. And that's assuming that everybody who has any kind of even very mild symptoms would present to health services. But let's say we're able to increase symptom monitoring and have 30% of our population present to health services for symptomatic testing. That would improve detection, improve our ability to detect outbreaks early, and also reduces the sort of marginal benefit of our asymptomatic program. But regardless, we find that we really need to test greater than 75% of our month to detect less than 10 detectable infections, and that limiting class sizes has a really strong impact on mitigating risk of transmission. Now, neither of these strategies is a substitute for one another. They need to be working together in order to detect outbreaks and prevent their further transmission in the community. And one of the limitations is that we do not account for super spreading events, which, as we've seen in the news, can result from one individual infecting, many other individuals. Now, another important study by Emory used an individual-based network model, also including students and faculty and staff parameterized to the Emory situation. And this model was looked at various combinations of asymptomatic screening with various intervals combined with symptomatic testing, as well as the impact of case isolation and contact tracing. And here, this is a fairly complicated slide, so I'll walk you through it. The slide shows the cumulative student cases on the y-axis. The x-axis is screening interval for their asymptomatic screening, ranging from 20 days to 100 days. And the different colored lines show the test delays between symptom onset and seeking a test for symptomatic individuals. Now, the three boxes range from 0% contact tracing, all on the left-hand side, to 50% in the middle and 100% contacts traced on the left. So if we're just looking and comparing the three boxes from no contact tracing on the left to 100% of contacts traced on the right, we can see that the cumulative student cases reduces dramatically when we incorporate contact tracing in the model. So tracing a high proportion of contacts is essential in order to control outbreaks on campuses. Now, looking within boxes at the colored lines, we can see that reducing delays to symptomatic testing from 7 days in the green to 2 days in the red is also critical at reducing the cumulative burden of an outbreak. And finally, if we look within the lines at the relative benefit of asymptomatic screening, in this model, they found that asymptomatic screening was beneficial if it was performed at least monthly. Now, a critical assumption in this model is that 35% of students were asymptomatic. And so, 35% of students were symptomatic, and therefore 65% were asymptomatic, whereas in our previous models, we have looked at much higher asymptomatic rates. And so that could definitely affect the relative and marginal impact of these asymptomatic testing programs, as I just presented. Now, importantly, this model doesn't account for, behavior change through masking and other behavior change or classroom sizes reductions and how those can interact to affect our ability to control outbreaks on campus. And that was really addressed in the next study that I'll talk about. And that is the University of Penn and Swarthmore model. So this is an individual-based network model, again, also including students and faculty, parameterized by UPenn. Now, the interventions that they examined were combining what I've talked about before. So combining contact tracing, asymptomatic testing, as well as interventions such as class sizes, online transitions of classes, and requiring masks and social distancing. So really kind of bringing it all together, all the modeling that I've shown you already. And the outcomes that they were interested in was looking at infections and quarantine populations. So similar to what we found at UCSD, one of the first things they looked at was the impact of in-person classrooms. So the left-hand side shows the distribution of class sizes before an intervention, with the vast majority of classes being smaller in the 10 to 30 range, but there were 8% of classes in the 50 to 99 range, and just a couple percent of classes that had class sizes over 100. This is pretty similar to what we saw in UCSD as well. And on the right-hand side, you can see, like we saw, that there was a dramatic impact of reducing those very, very large classroom sizes. So a dramatic impact in the total number of infections as we create classroom size caps of, 80 or even 60, but kind of a marginal impact of further reductions in those class sizes to the very small classes. And here what they're showing is the impact of each intervention on the total cumulative number of infections on the left and the peak quarantine population observed in the right. Now, quarantine populations are the populations who need who are contacts of cases that have been identified that need to quarantine for 2 weeks in the event that they develop an infection and could transmit it to other individuals. And so the issue of quarantine population is very important for university campuses because they need to provide both isolation housing for the cases, but also quarantine housing for the contacts. And in many settings, individuals may have up to 10 or even 15 contacts per each case that require quarantining. And so this quarantine population is very important in terms of being able to provide adequate housing for them during this period. So if you look just at total infections on the left, what you can see here is how the cumulative number of infections changes as we take away different interventions. So for example, in the middle with the largest bar, you can see that with no online transition to courses, the peak cumulative infections could be very high. And really this online transition and classroom caps and hybrid teaching approach is really the most important part of minimizing transmission risk on campus. Again, echoing what we saw in the UCSD modeling. The second most impactful intervention in isolation was mask wearing, and indicating and underscoring the need for students to actively participate in social distancing and masking interventions. As well as the other interventions obviously are critical in terms of contact tracing and testing. Now, if you look on the right-hand side, we see a similar picture in terms of the importance of online transitioning and mask wearing in controlling the peak quarantine size. But another interesting thing occurs, which is at the top bar. So the top two bars look at the interventions in terms of symptomatic and asymptomatic testing, with the very top bar using high accuracy testing that has very high test specificity, and the standard intervention including kind of a lower test specificity. And what this is doing is really emphasizing that if you have a test that you're using for asymptomatic testing that is not very specific, meaning that you can get false positives, then, as you would expect, those false positives would lead to needing to quarantine many of their cases. And so you could potentially really inflate the impact of your asymptomatic testing program in quarantine population housing need. And so having a very accurate test is important in minimizing the quarantine housings that you need. So in conclusion, I think we really go back to the three pillars that we've had in terms of the UCSD approach in the importance of risk mitigation. The modeling broadly supports that masking and social distancing is essential and that classrooms are important bridges of infection. Classroom caps and hybrid instruction is critical in terms of reducing the risk of transmission on campus. Viral monitoring is also important. Symptomatic testing without delays is critical to identifying infections early and preventing transmission. Asymptomatic screening with at least monthly testing is beneficial for reducing transmission and allows us to detect outbreaks early. But low test specificity may increase quarantine housing needs. And finally, public health intervention is critical. We need a high efficacy of contact tracing, which is required in order to really prevent further transmission. And finally, I would just say that modeling has been incredibly valuable in terms of thinking about campus reopening strategies. And I think that we should all push towards this approach of really upending the traditional public health model and taking intelligent and data-driven decisions, both in terms of how we reopen campuses, but also how we reopen society as a whole, which can help use modeling in real time to proactively mitigate COVID risk, both for the campus and the wider community. Thank you.
Thank you very much, Natasha. That was lovely. I just want to take a couple of moments before introducing Arnie to answer a few questions. First of all, I've had a lot of comments about the audio being a bit iffy, and so we are on the case with that, and the tech people are working on that behind the scenes. This is being recorded and will be made available after the webinar is over, so we will be able to get access to the slides and the audio after this. And Natasha, there is one question that came in that I'd like to pass on to you if I can. It might be a bit too detailed, but the request was, can you give us more detail on how the modelling was implemented, the tools, the granularity of the agents, enough detail to help others build similar models for their environments? And I appreciate that might be a very big question for just a couple of minutes.
No, that's a great question. And what I'll do is I will say that some of these models are actually already available online. Unfortunately, not yet the UCSD model, but some of the other models that I have mentioned are available on GitHub, and the full documentation is there. So what I will do is I will send the information to the organizers, and I encourage, there are both MedArchive, the references to the papers are online that have much more granular detail in terms of how to reproduce the models as well as the associated code. We also plan on making our code available when it is ready for sharing.
That's brilliant. Thank you very much again, Natasha. Right, I will hand over to Arnie now for his presentation. Go for it, Arnie. Take it away.
Okay. Yeah, thank you, Sarah. And I thank all the organizers, Professor Stephen Krantz and Dr. Shala Callaghan. And thanks for Dr. Natasha Martin for giving a brilliant talk. And my presentation is organized as follows. First, I will talk about the artificial intelligence model, and then I will talk about the mathematical model for COVID. When the COVID epidemic started sometime in December 2019 and the January, we were not very sure that the number of cases all over world will trigger that rapidly, and we were not sure about the definitions at the time. So back in January, I developed a model for the identification of coronavirus or COVID. At the time, I thought that it is more important to understand the growth rather than identify the cases. So that's how this model been developed. And once the model developed, and then I thought about the idea based on the CDC's and WHO's guidelines to identification, I approached my clinical colleague to whether he can collaborate with me, and then that's how this, we wrote a first paper back in February sometime. That's about identification of coronavirus using the apps and the artificial intelligence modeling. And this is the first AI model for coronavirus identification anywhere in the world. And then later, several hospitals and then various universities they all approached us to make these sort of models, adaptable for their own situations, various population, whether we can do subcontinental, continental, various industries, airline industries. They all approach it because this is first model which should demonstrate that AI model can help to identify. And in the first phase of the model is about data collection. We collect the data through travel history, through signs and symptoms, through mobile phone based survey. So, and once the data has been collected at the back end of the data is handled through AI model. And then the AI, the hospital based, the data is processed at the hospital, and individuals, those who responded through the mobile phone based survey, they will be sent an alert within a minute whether they are likely to have the coronavirus risk and they need to go to a nearest testing center, or they don't have to worry. So this is what about the backend. The backend AI model immediately sends within a minute to the users of the mobile phone based survey whether they need to go. If they have to go to a center, that mobile phone also, the alert also consists of where they should go, the geographical location based on the respondent's location, that will advise them to where to go. So in that sense, the app and the model work together to make a decision instantly, to make a decision to go for a testing. And then the pictorially, if you see that, suppose this is a geographical region, we have a geographical region, and then we have households within the region. We are demarcated, and then within a household, and some of the individuals respond. And for example, say here, the blue dots indicate those individuals who respond to the mobile based survey, and then yellow dots are those who never respond. And then some of the non-respondents also might have the risk of having coronavirus, but we cannot help unless they respond. And here you see that some of the some of the non-respondents, the yellow dots also have the could have the virus, and some of the here anyway the respondents, the app anyway detects, the model anyway detects those who have the virus potential to have go for testing. The red circles are those individuals who received alert that they are likely to have virus. They should go for testing. And this is all about the idea of the model. This is the model, and the details, the technical details of the model is completely there in the published article I showed at the beginning. And then the one of central theorem, central ideas, what the theorem, the theoretical aspect of this particular paper, other than practical implications of that is it can tell that what is the probability that an individual who responds to a survey will have a probability to identify. So what is the probability that a given individual respond to survey that person will have likely to be identified as having coronavirus? So this is one of the key theoretical outcomes of this particular paper other than the practical implications. And then my second part of my talk is about mathematical modeling. And here, my main collaborator in this entire mathematical modeling of coronavirus is Stephen Krantz. So Steve and me, we have been collaborating for last 3.5 years. Although I know Steve we know each other for last about a decade. And Steve wrote very classical textbooks in the mathematics, especially complex analysis. And then me and Steve, we thought of working together on the understanding the underreporting in general. So we have been working on a very deep mathematical methods to understand, using the deep mathematical methods of harmonic analysis and wavelets to understand the underreporting for last 3.5 years. And then our first major article came in this year in March, that is in the Journal of Theoretical Biology. And then we published all the detailed mathematical methods of harmonic analysis. How do we use the harmonic analysis methods to get a complete picture from a partial picture? I mean, if you have a partial data of an epidemic reporting, from the partial reporting data, how do we obtain the complete data? So it's not easy to obtain that, and wavelets could help us to understand that. So we developed a complete mathematical analysis through this article. And that article exactly came around the same time when the coronavirus started grow. So immediately we applied that particular paper to understand the coronavirus in 9 different countries. And then the idea is to, if you have the AI, BI, or the number of reported and total number of cases, we never know what are the cases which are never reported. Only what we know is only reported number of cases. And the idea is to obtain the total number of cases from the reported. And this picture shows that even though we have a reported number of cases within a time interval, unless we know exactly who are they, we cannot control the epidemic. Because once we know the individuals who are reported, we need to control them. Just by knowing the number of reported, that is not enough for us to control the epidemic. And then as you see that here, the network. So we developed graphs using graph theory. We developed networks, and then using the networks, number of edges, number of vertices, and then we try to identify those individuals who are actually having the virus in them. So that's why not just the idea is not just having the number of infected, but number of infected combined with the particular individual and then geographical location of that. And then we try to also readjust. That means number of cases reported need not belong to the number of cases who are actually the incidents occurred in that particular interval. So we also, in that particular paper, Krantz and Polyakov-Rao, we try to readjust the data of reported cases into proper intervals actually to which that particular case belongs to. So this readjustment is also we proposed, and then using the readjustment, the accurate basic reproductive rates or accurate incidence rates can be obtained. And then immediately once we have this methodological paper, we immediately applied that to coronavirus. So first what we did was we considered using wavelets, and then we try to understand the the difference between the reported and the total magnitude, actual magnitude. So the basic assumption is that actual pandemic preparedness depends not only on the reported cases but on the actual true cases in the population. Unless we know the true cases, the pandemic preparedness is not complete. So what did we do? First phase, we considered 9 countries. Those were already started to show some sort of increase in the coronavirus until the first week of March. And then at the time, the US, the number of cases was so low, and no one expected that the number of cases would be so large at the time. And then the number of, up to March 12th, if we see that these are the 9 countries, these are the 8 countries, and then we have also UK, but UK didn't have enough cases that time. So these are the countries we considered, and then once we selected these countries based on the magnitude of the total number of cases, we considered the dates in which the peak occurred, from the 10 or above cases to the first peak. So each country, you see that different countries have different peaks, but more or less the Italy, Iran, South Korea, Spain, Germany, the all countries follow the same pattern, almost the peak. The first peak occurred within the same interval. And then once we have this data information, we also consider the population density, urbanization, daily new cases, proportion of population in these particular intervals, and then we obtain the reported. We obtain the number of what is the ratio between the reported to the total cases. So in this case, for example, for China, we obtained 1 out of 149 cases are only reported to 1 out of 1104. If we use the Wuhan data to project for entire country, that's what it looks like. Using the model-based, we compared the model-based predictions versus the actual data reported. And then for Italy, you see 1 in 4. That means out of 4 cases are there in the population, 1 was detected during this time period, during the date range, and 1 in 34 in Iran, 1 in 4 in South Korea, 1 in 5, 1 in 53 in Spain, 1 in 3 in Germany, and 1 in 406 in US. But the data in US, as I mentioned, is not sufficient because the first peak has not arrived by then, and then we just try to recalculate later for the US data. And then what we found was, as we all know, that wavelets are improvements over the Fourier transformations. And Fourier transformations have sine and cosine functions, and then wavelets are improvisation of that. And then we found that the predictions for Spain, Italy, and Germany, and South Korea, they all came out to be true. When we predicted in the first week of March, whatever predictions we have done, based on the reported cases, we saw that later, by end of March, they came out to be true. Italy, we predicted the reporting was not accurate. And then we saw that end of March, the total number of cases in Italy really grown enormously because of so many underreported cases. Same as Germany, if you see that they controlled well because the reporting was, they could able to identify more number of cases. And same as Spain, the identification was poor. That's why you see that wavelets, the dotted line and the thick line, the difference between the dotted and thick lines indicates the difference between the true magnitude and the actual reality observed in the population. When we recalibrated the data for the US in the middle of March, we found that out of 4,000 reported cases in the US, there might have been 90,000 actual cases in the population. See the difference between the reality and the reported and the actual observed data. That's how the difference between these two magnitude of these two differences. You see that the thick line is the true population, true infections in the population, and the dotted line indicates the reported cases. And then once we have obtained this information, we try to predict for all the other countries, various countries. We received requests from various European countries, other countries. We also done for India, done for Brazil, many other countries. We try to obtain the underreporting. Various countries approached us to predict the underreporting for them. And then we are also launching a special issue for the Journal of Mathematical Analysis and Application, which is one of the oldest mathematical analysis journal in the world. Myself and Stephen Krantz and Juan Nato, we three are editing the special issue for the journal. And the mathematical model, two parts of modeling work we have done: identification and modeling. As Natasha rightly mentioned, the modeling, they need to be refined based on the new asymptomatic cases. So by the time we developed this model, the asymptomatic cases were not that many. There are not many people who are asymptomatic among the tested. Then the asymptomatic people also increased over the time. So the modeling need to be updated continuously. And this particular model at the beginning phase where we developed were really helpful for various planning and purpose for various parts of the world. And a lot of media coverage. We want to thank all the media coverage, about 100 to 150 media outlets all across the world. They covered both our AI modeling and then the mathematical modeling for underreporting. Thank you.
Right. Thank you very much, Arnie. That's really appreciated, and thank you for the talk. So we've had a few questions come in, so I will read them out and pass them over. For those who are still listening and attending, please do feel free, if you have any other questions, to put them in the questions box, and we will get onto them. So Arnie, I had a question which was, going back to one of your earlier slides, it was, how is the first peak defined?
First peak defined up to the number of cases from which the downfall started.
Yeah, I think so, yes, but I don't know. The question is simply just, how is the first peak defined?
Yeah, the first peak is defined as the number of cases, the day from which number of cases started declining first time. So if the March 9th, I think that for the Italy, when we saw that, after March 9th, the first time they saw there is a decrease in the reported cases, but then that's the first time, we didn't realize that first peak was a fake first peak. There are really, the first peak might have, real peak might have occurred after a few weeks after that, but the first reported peak occurred on the March 9th. Then after the next few days, there is a decline in number of cases. But again, there is an increase, there is an increase in number of cases later. So first time that number of cases we started declining, we defined as first peak. Any epidemic, you see that first peak is the first peak.
Oh, so the questioner has come back with another comment. Says that because in the US is marked as March 12th, but that was actually the start of the confinement, they said.
Correct. As I mentioned, the number of cases in the US when we developed this model, that was, they just started to pick up, and we were not sure that, where it will go. No one could imagine that will touch 2 million cases. So the 800 cases what was reported by March 12th, we didn't see any peak. The cases were still rising, but we didn't see that number of cases declining by then. So that then we recalibrated in the middle of March. Then we thought the same modeling parameters, whatever applied for other countries, if we apply the similar parameters for the US, there might have been 90,000 cases in the middle of March, whereas reported were only 4,000.
Yes, so that actually ties in with another question that we got, which is, as you say, there's a seeming underreporting of cases in the US, the 4,000 versus 90,000, and the question is, what can we make of this underreporting? What does it tell us?
Correct. That's a good question. That's a brilliant question. So underreporting tells us two things. One is that the magnitude of our surveillance, what level of surveillance we are doing, the epidemic surveillance, and then other things says that the spread is happening. The higher the underreporting, that means many individuals are could be spreading the epidemic unknowingly, because they are not quarantined, unless their lockdowns have not started. Those who are not reported, but they have the virus in them, they could be still spreading the virus unknowingly. So that's very important to understand. So that's what, this is the first time when we developed this model for underreporting, that actually attracted a wide attention in the media, other places, to other articles also. Various people cited this work including the Department of Homeland Security in the US. They have also a list of references. They mentioned, the importance of underreporting. Everyone thought the reporting is complete, because the testing numbers are so large. Everyone thought reporting is complete, but no, still there are many people who are not being reported.
Great, thank you. Yeah, and data collection is always really, really difficult in situations like this. And of course, without good data, it's very difficult to understand what's going on.
Correct.
and make sure that the results of our models are actually predicting what we think they're predicting, and that. So yeah, modeling and data collection is really important. So
Correct.
I've got quite a lot of questions about the details of your models, things like what type of wavelet is used and what the period of the sample collection is,
Correct.
and
Absolutely. I
more
forgot
details.
to. Correct.
Yeah, yeah.
I'll be happy to. Yeah. We use the Myers wavelet. I should have mentioned in the beginning. We use the Myers wavelets, and the functional form, everything is there in the published articles. We published in the Journal of Theoretical Biology, Journal of Infection and Infection Control and Hospital Epidemiology, which is the official publication of the IDSA. We use the Myers wavelet. The technical details, and Meyer wavelets are one of the flexible, and then the functional forms. And although it's a complicated, it can capture a lot of variations in the data.
Great, thank you.
Did I miss any part of the question? That's it.
So there's so we did have a question about what type of wavelet is used.
Myers wavelets, Myer, Meyer.
Okay, great, thank you. Right, so there's as I said, there's lots of questions about the details that I'm sorting through at the moment. One other question for you, Arnie, is did you consider mobility in your model? And if yes, how important was it? And if no, why?
I think that's a brilliant question too. Mobility is very important. When like a basic reproductive rate, we cannot compute the mobility parameters under the lockdown conditions. It is simply impossible. Even though we compute, we might collect the mobility data on a sample basis, but a population level mobility is very, very important. I agree with the questionnaire. I agree with the gentlewoman who asked, the lady asked the question, but then we could not have the mobility data, but we have the population density, we have the level of urbanization, population distribution by age groups. By the first peak, we considered 9 parameters, but mobility was not considered. We assume that person reported geographically, generally wherever the person is living. That with that infection, we try to account that particular infection and the number of infected particular geographical location. We didn't consider the mobility. We don't have the data actually on the coronavirus, the travelers information. We don't have no database actually. We looked at the CDC and WHO databases. We don't have any data on mobility.
Great, thank you. And the flip side of mobility is, well, if you don't have mobility data, you can't. It's hard to estimate the effects of lockdowns. Is that an accurate statement to make there? The question
Correct.
was, how do you observe and estimate the effects
Absolutely.
of lockdowns?
I agree with you, Sarah.
Yeah, great. Okay. Yeah.
If I jump in here.
Yeah, please do.
Okay. I mean, this is a really critical question. I think it's so interesting. And one of the things that I think has helped us understand this a little bit is there's a work done by a number of teams, but one of them, Antoine Callaghan here at UCSD, that's taken viral sequencing data to try to understand the impact of the lockdown on transmission clusters and genetic evolution of the virus across the United States. And so actually looking at the sequencing data can help us disentangle that, because what he's seen is that if you look between states, there was quite a lot of transmission of virus before the lockdown. And then when the lockdown happened in the United States, through the sequencing data, you can see that there's less transmission across states. There's still quite a bit within states, but that cross-state transmission really dramatically declines. So I think the sequencing data can be very helpful in understanding this. And there's a whole class of models they're being developed, phylogenetic models that are really interesting, that kind of overlay the molecular sequence data with a dynamic transmission modeling approach, and really leveraging both the epidemiological, perhaps behavior, as well as molecular data to help us infer these effects.
Great, thank you. Yes, absolutely. Yeah, so I have a question that's come up that I think is actually suitable for both of you. It's a high level one, but I think it's very interesting. So it's the question is, if the next pandemic comes up, what would you recommend from the modelling point of view in terms of implementing monitoring or additional measures that we should be integrating into our daily habits and lives to be more prepared for emerging diseases?
Should I, Natasha answering, or should I answer?
Yeah, go for it, Arnie. Yes. And then Natasha, if you have any thoughts on that afterwards, that'd be great too.
Yeah, thanks, Sarah. Yeah, there is no general rule. We cannot have a prefixed rule, but always better to have a good habits, hygienic habits like washing hands, irrespective of whether we have a coronavirus or not. Washing hands, come back home, be clean. Keep your environment safe. I mean, that's important. In any pandemic, we don't have unless the next pandemic comes and the properties of the virus are clear. We cannot have any prefixed rules. In fact, me and Steve, we are writing our next article. I mean, already wrote our next article on the digital health technology. So the main argument here is, come what may, digital health technology can never able to predict the next pandemic. That's it. Yeah. Over to Natasha.
Yep. So the only thing I would add, I mean, I totally agree. And I actually hope, as a mother of two small children, that this will fundamentally change our, kind of approach to hand washing, and having everybody use the WHO hand washing recommendations is good. The other thing that I think that I hope to see kind of a long-standing effect is masking and face coverings. And obviously, in the United States, that has not been traditionally widespread. There are certainly obviously other countries, particularly in Asia, where that is a more commonly accepted practice. And I think normalizing of mask wearing, particularly in flu season, would have a lot of benefits. And I'm curious to see whether that kind of stays after this particular pandemic wanes. And the last thing I would add is, I mean, the question I think was, it seems that it was about monitoring at an individual level, but as Arnie mentioned through his presentation, and I think what we've seen more broadly is that, monitoring both from at an individual level, but also having really strong public health monitoring and surveillance is critical. And the U.S. is seeing the effects of having a fragmented and basically ineffective public health monitoring and case notification and contact tracing system, as we see the epidemic continuing to rise here. And I think that is going to be absolutely critical in strengthening our public health monitoring infrastructure in the future to address any future pandemics.
Great. Thank you very much, both of you. Yes. It's definitely good advice to keep washing your hands, and just being aware of this, I think, is really, really important, because I think the questioner is right. There will be more of this sort of thing coming up in the future, and we need to be prepared for it, and that's perfectly all right. So I have another question for the both of you, if that's all right, which again is a more general one. So perhaps, Natasha, if I could start with you and get you to answer this one first. The question is there any approach in AI that can get implemented in future to predict if the person is infected or not? And this is based on current work.
Yes, this is fascinating. So one of the technologies that's being pursued at UCSD is trying to incorporate sort of biometric monitoring with artificial intelligence systems to try to collect kind of big data analysis of individual level data, that can be collected in real time in terms of pulse oximetry, temperature, behavior, all those kinds of things integrated to try to predict whether that person is likely to be infected or have subclinical infection. I think it's a very interesting research question. We have a lot of we're developing the technology to be able to collect these data, and it's going to be really down to the environment, the sort of AI and the technological sort of analysis of these data to see how useful they'll be. I mean, the other things that these wearable sensors can do that I know that are being developed are things like monitor the temperature and the airflow in the room that a person is involved in, and air circulation and all of those things. We know that aerosols play a role. So it could sort of integrate both individual level data in terms of their clinical symptoms as well as environmental monitoring to try to predict whether a person is infected. And I think it's a really exciting area for the future.
Thank you, Natasha. Arnie, do you have any thoughts on this particular question?
Yes. I'm a big supporter of AI. The impact of AI is going to create is enormous in the future. However, given the implications of AI for pandemics, I would rather think that AI can do something only when a human is already aware of they observed in the lab some properties of the virus. AI can never reach a situation where a human cannot imagine. I think that would not be there, and that would be simply not possible because that AI works on a very solid mathematical arguments, and then whatever the predictions they do based on the data, what a computer will have or the computer systems will have in their own, the data, the feedback they receive on the data. So if something is not observed in the lab or something with a human, some well-defined things are not there on the virus, AI cannot, digital health cannot do. That's what I mentioned in our next paper. An argument is already received wide attention, an alternative point of view on the AI. I'm a big supporter of AI, but AI has its own limitations.
Yes, absolutely. I think there's a lot of potential and a lot of promise to for AI to help us solve the great problems that we're facing at the moment. But there's a lot of complications that we'll be facing along the way. So it's not going to be a perfect solution for us. But it's something that is worth investigating, definitely. So I noticed that we have officially a whole 2 minutes left of this webinar. So I'd like to take those last 2 minutes to thank the presenters, Natasha and Arnie, again for their wonderful presentations, and also to say thank you everybody for coming along this afternoon for me in the UK, but or whatever time it happens to be for yourself. We will make the recording available of this webinar with the audio and the slides, and that will be sent. The details of how to access that will be sent out later on. So I'd just like to say again a final thank you to the audience for logging on. And a thank you again to our wonderful presenters for giving us such interesting and enlightening presentations today. So thank you very much, everyone.
Yeah, I want to thank also Kim and Simone. Both of them, they've been working hard for several weeks to help us all.
Agree. Thank you so much for the invitation.
Yes, and yes, thank you to all the team behind the scenes as well. Really appreciate it. Okay. Thanks, everyone.
Yeah. Thanks, Sarah. Thanks, Natasha. And I want to thank Steve.
Thank you.
Yes. Thank you, Steve.